Swayam Prabha. Digital India. Educated India.
Welcome to our course on health economics. As part of the NPTEL MOOC program, which is the most important program of the Minister of Education through the NPTEL. So, in this lecture, we are clarifying the fundamental concepts or the terminologies which are used in health economics. Hence, we will be discussing what exactly we did in our entire 12 weeks module, and I have already introduced you about the efficacy or the best benefit for the professionals, for the students, for the healthcare professionals in particular, and also those who are heading for a certificate and those who wanted to in fact go for getting projects, sponsor projects, consultancy projects. The entire module is indeed going to be useful. Some of the weeks are very interesting and highly applied, like health efficiency and by program evaluation or the health not program in particular. We did not take the name of program in our model, but policies evaluation, and in particular we discuss is economic evaluation of the health policies. Those chapters are very essential, and some other chapters also give you the direction for understanding the data sets around micro and macro and the tools and techniques to deal with this data, to analyze or to get a research project, okay, and that can be presented, that can be also deriving as a policy paper. So, in all through we have tried to focus on different concepts and application of health economics. Hence, in this particular lecture, I will be giving you the key concepts in health economics. In health economics involves various stakeholders which are dealing with their actions, and since they are conflicting, hence a solution is required. So, although most of the concepts and terminologies used in the lecture are dealt in their respective unit in itself, they are dealt in detail, but at this moment I will give you those in nutshell, so that you might have interest to read further. And I am sure that you can also think of whether this can be, that particular lecture can be attended, can be rechecked again for your own learning. Like I am just giving you what we have done it, I am just showing it, I will explain you what I have done it here, I will come back again. So, in some lectures we discuss about the possible solutions to maximize the utility when a person is having targeted with certain factors, such as in their consumption model. We used to in our typical demand theory, we used to deal with consumer goods which are exposed to the consumer, but now the same person is not just a consumer, is also carrying certain health state. Hence, the consumption basket depends on the level of health the person is carrying. I am not going to clarify what is this optimum with S equal to 0 at this moment. I am clarifying in its respective unit. You will find somewhere in our week. You will particularly find these things in our demand in healthcare, in supply in healthcare. especially in sub unit number 3, unit number 2, etc. You will find it in detail. So, I will suggest you to read and get the details. We have tried to derive each of these direction and explained you. What I am mentioning just for your sake of interest is that when a person is heading for a consumption basket, his person is actually juxtaposed with the carrying capacity of resource allocation. So, what is that carrying capacity? Whether a person can able to carry forward or not, it depends upon his health level. So, the health level is another commodity, another commodity as part of the health basket, as part of the consumption basket. So, we try to optimize in what level the consumer can able to actually optimize it. And again, in typical microeconomic theory, we used to explain the constant optimization through the constant linear optimization or linear constant beta optimization. But at this moment, in this module, we have tried to discuss about the on constant optimization as well. We also try to talk about when the constant function is not linear, where we are supposed to use the Kohn-Tucker theorem. So, Kohn-Tucker theorem is also not just Lagrangian multiplier. Yes, we have also used initially, then we extended to the Kohn-Tucker applications as well, where the boundary optimum and interior optimum etc. we discuss our best. I am sure that it will be expanding your thinking. In addition to that, we initially started explaining about what is the health state, and it depends upon their marginal utility and total utility. But what we perceived, the marginal utilities and the difference in the society based on the health state, how the next level demand is generated. That is why somewhere we try to emphasize the negative health state dependence. I am sure that these are going to be your doubts. So, hence please go through that peak, we will clarify. To explain these things, we took the help of the Grossman model. That is why I have just taken the snapshot of my respective lecture graphs, and we try to discuss there about trade off between health and consumption. We try to explain the idea of Grossman's on human capital formation through the health as an investment or an human capital. And interestingly, the production possibility frontier which we derive in general, it is not just a concave structure. It should not just start with an optimum point. It might start from a H minimum, health minimum level, okay, and may end with a certain extreme point where the person is ending his her life. And hence, this portion which is highlighted is actually mentioned over here, okay, and where we try to we have given our direction to explain you the maximum possible solution so far as health economics is concerned, okay. So, you will find in our respective chapter, I am sure it will be helpful. Similarly, we have taken a leap further in understanding the health systems in detail. Health systems including the marginal social welfare etc., how if persons are actually exceeding their consumption, or person is taking more such type of over consumption, how it is creating some forms of threat, and hence a health system might not function well, okay. So, however, a dedicated chapter is on health system, economics of health system. We discuss about their tax and social health insurance mechanism. We discuss about private financing mechanism, and we also cited the examples of different health system in the world. Thereby, we have explained examining their the efficiency, productivity and efficiency parameters. So, we have to taken the help of parametric and non-parametric tools. We have emphasized the non-parametric tools in detail using the data involvement analysis DEEP. We have also used the DEEP software. Okay, DEEP is a DEAP is a free software. We have guided in the respective chapter. If you remember, if you might have read regression as well. If you haven't read, if you haven't read microeconomics, it's still fine. I think this module we have made it to every learner, and especially in parametric, it takes the help of a distribution. We try to explain the regression tools, but not in detail but we have emphasized in that chapter on data environment analysis. Okay, we have also guided you how to reach to the level and how to reach to explain stochastic frontier analysis as well, but though we haven't discussed in detail. And so far as health efficiency is concerned, as I told you, we took the help of the DEEP software, and this is how it looked. And I am not clarifying everything. These are all explained in our earlier in our later recordings, and where we discuss about the CRS based model, BCC input and output model, all possible starting explanations are made, okay, including their slags and targets, how to optimize, how to reach efficiency indicators, and how to develop index as well based on the best indicators are also discussed in other chapters as well. And so far as the evaluation is concerned, the economic evaluation concerned, we have tried our best, attempted to understand the cost saving techniques. We attempted to discuss the possible tools, cost benefit analysis, cost utility analysis, and even various tools of economic evaluations are discussed in detail, especially in week number 8 and week number 9. And like you can read through this diagram, there are situations which is clarifying whether we should go for more cost effective one or less effective model, or we go for any new intervention or not, whether how far it is useful. So, these are all the glimpse of our different chapters. However, we have only captured 4 or 5 important snapshot. There are so many, okay, since we have around 60 lectures. All right. So, let us explain some of the concept for your reading and for your understanding to start with, and this will subsequently help you to take off our different slides correctly. We have used jargons and broadly let us divide them into basic economics jargon and health economics jargon. Choices in basic, it refers to the decisions made by individuals, firms, government on what needs and what wants to satisfy, and what products and services to produce or provide. And choices are inevitable due to the scarcity of resources. So, again scarcity attached with availability of limited resources, and the society's needs, wants, since are unlimited, hence the decision making is very important. And the role of market, where market is a physical or virtual space where buyers and sellers are transacting their contracts, okay, and they exchange of goods, services and assets to find out the best value. And regarding disposable income as a concept, we have also used to explain how far this is creating a threat to the individual as a burden, or maybe creating some catastrophes on them. And so far as resource allocation as per the provider is concerned, how far they are actually allocating the best, including the taxes, and how far they are actually generating for the social welfare, etc., are also linked. And so far as the basic economics jargon are concerned, from the consumption side, demand is presented, demand, utility, utility functions. Just for half a minute, I am going to take it to explain all these things. We sometimes are confused with demand, with wants, then utility, then satisfaction. These are largely interchangeably used. However, when demand is concerned, it presents the quantity of good and service that consumers are willing to and able to purchase at various prices during specific period. And in economics, sometimes we use as called quantity demanded quantity demanded when quantity demanded when we are restricting to a particular commodity, when we are restricting to x and its respective price of x. Okay. So we will find out such things in our model, but not in detail because they are very basics. And utility is basically a measure of satisfaction, and the utility function we have presented is a function of a combination of goods and services. And indifference curve, where in microeconomics we used to explain a set of combination of commodities presented in a graphical space, where it derives an equal satisfaction to the consumer with different combination of two goods. Okay. And when the combinations derive equal satisfaction out of all those combinations, which is indeed the best combination, is where the lies with the decision making. Hence, it is important, and we have tried to use, we have also used production possibility frontier to represent whether it should be convex, it should be concave or not, and in which context it is useful. It is also useful in efficiency analysis, it is useful in our also supply side analysis. Okay. And these all details, so far as production is concerned, we actually discussed this. I have just said we have used isoquant, we have used isocost. So the clarity for this is that isoquants, again likewise the indifference curve, it's a combination of inputs and which give same level of output, keeping other thing constant. We have also referred its chapter number for your clarity, if we are limited with our time not to give more emphasis on it. So we have actually emphasized its respective reading. I am sure with little extra time allocation you can understand. Isocost, it represents the combination of two inputs and their cost, the combination of their factors and that result in same total cost, and how these are useful in our work. So we have used cost and benefit analysis. Cost refers to the value of opportunity, that is forgone, and that is indeed considered to be the best measure of the cost. And even if you might have heard about companies who are recruiting their persons, they are these days giving CTC salary, cost to company salary. They include all possible cost. Okay. And marginal benefit is the additional satisfaction derived from consuming an additional unit of service or product. Marginal cost, of course, is the additional cost incurred by producing extra more unit of production or service. So the jargon such as used in health economics are epidemiology field, are like the frequency, especially in epidemiology field we use frequency and distribution and determinants of disease, and we try to evaluate the clinical effectiveness of those different forms of care. And we use indirect cost, that refers to the losses incurred by society due to the impact of disease, illness and treatment. They include losses incurred from an inability to engage in normal daily activities, work, domestic responsibilities and social and recreational activities, etc. Direct costs are also explained. This uses resources for their direct treatment and healthcare process. Intangible benefits, that relates to the issues such as improvements in health and well-being or quality of life. Intangible cost relate to issues such as anxieties and the impact on quality of life resulting from participation in various programs. They are generally difficult to be measured, or these are generally difficult to measure and value, and often not included in the construction of the cost profile of an economic evaluation. We have used also the concept called willingness to pay as part of our economic evaluation, principles of economic evaluation, chapters. WTP, or willingness to accept, is the maximum amount of money an individual, in this case we are explaining WTP is the maximum amount of money an individual is willing to pay or give up to benefit from a particular intervention. So, suppose for an intervention in a program, you want to evaluate a government program, how far they are willing to pay. Similarly, willingness to accept is the minimum amount of money an individual is willing to accept to not benefit from an intervention. So, again, what do you mean by intervention? It refers to any treatment, maybe a drugs, device, therapy or policy that is used or attempts to improve health or health outcome. Effectiveness refers to the extent to which is given intervention or service produces health outcomes in individuals who are offered that intervention or service. So, basically the effectiveness refers to specifically the health outcomes. Similarly, some concepts are used in different books you will find, such as HTA, Health Technology Assessment, that is precisely a systematic evaluation of properties, effects or other impacts of healthcare technology. It is designed to provide objective information to support healthcare decisions and policy making. Some financial incentives are also as part of the discussion. This refers to potential to influence professional behavior by affecting either their income or expenditure related to alternative decisions. Efficacy is usually used in our module, that refers to the extent to which a given intervention or service produces a particular health outcome in individuals who fully comply with the recommended treatment under ideal clinical settings. This is in contrast to effectiveness. Please take a note, which we have said we are actually targeting a particular health outcome, okay, when efficacy is discussed. Economic evaluation as a term we have used largely, that is on economic appraisal, refers to comparing alternative courses of action in terms of their cost and consequences to make a choice. And more interestingly, we have used the quality of life indicator, citing the health related quality of life, that is HRQOL, such as we have also taken the standard databases, standard systems which are using different health related quality of life indicators. And most importantly, we have discussed about quality adjusted life years, and we will also refer in that respective chapter about what about UK, what about US, what about Finland and their model. We have also tried to give you the all possible health states in that chapter to measure the quality adjusted life years. We also emphasize on daily disability adjusted life years, okay. And even this is largely used in some context, though there are some issues of responses are not counted in daily, but large in quali you will get the details in the respective chapter, especially in week number 9, okay. And this HRQOL can be assessed using disease specific, generic or preference based measure tool. Cohort models, there are some concepts also used by healthcare economists or health economics chapters. These consider and characterize the average, but not the individual patient experiences. Hence, it is called cohort from a population that shares the same characteristics. Okay. So, decision tree and Markov models are the two most common cohort models. We are explaining of these in unit number 9. So, that is week number 9. So, other interesting aspects are called sensitivity analysis, which is a technique used in economic evaluation or decision analysis to determine how or where plausible changes in uncertain clinical or costing variables affect the main results of the analysis. Okay. So, efficiency, we have used efficiency as well as a term. This refers to optimal allocation and use of scarce resources. Two common and related types of efficiency are technical and allocative efficiency. Technical refers to the technical efficiency refers to the production of the maximum level of output for a certain combination of input factors such as raw materials, working hours, etc. Within healthcare, this term technical efficiency refers to choosing a program or an intervention to achieve a given set of objectives or a level of outcome with the fewest allocation of resources. Whereas, allocative efficiency refers to the decisions about the distribution of resources across a range of interventions within a given system. Interventions compete with each other for their implementations. Within the healthcare system, allocative efficiency involves the distribution of healthcare resources across healthcare programs and intervention. That is how much of these are actually allocated, whether to invest resources in a particular healthcare program or not. So, these are some of the important concepts we have used, but these are just some of the information. There are so many concepts we have also used. I am not taking through all these at this moment because this is just the introduction as part of our module. I am suggesting everyone please go through the reading. In our next lecture, we have started discussing about the health as an economic good as part of the introduction week only. Okay, so some of the important reading we have cited. Even we have also given the respective chapter with their reading in their respective lectures. Okay, and I am sure that throughout the entire 6 lectures it will be very helpful. And however, if you are still confused somewhere, we have live sessions for discussions. I am sure I am suggesting everyone you will raise some doubts. We will be happy to address it. With this, it is time to close here. Expecting your participation. Thank you.